Good morning, everyone. I'm Dr. Harkirat Talwar from Medanta, Gurgaon. And the article given to me is Outcomes of Grade Group 2 and 3 Prostate Cancer on Initial versus Confirmatory Biopsy, the Implications for Active Surveillance. This article was published in European Urology Focus with an impact factor of 5.996, and editor-in-chief was Christian Gratzke. So the potential candidates for active surveillance can be divided into 3 cohorts. One, which are the grade group 1 cancers on initial biopsy and they progress to group 2 or 3 on radical prostatectomy. The second are those which are grade group 1 on initial biopsy and they progress on a confirmatory biopsy. And third, which are the grade group 2 or 3 cancers to begin with on initial biopsy. So in the prostatectomy cohorts, the grade group 1, which progress to either 2 or 3, they have similar cancer-specific survivals. And this present study compared the groups 2 and 3, that is the grade group 1 cancers which progressed to 2 or 3 on confirmatory biopsy versus those which were 2 or 3 on initial biopsy. As we all know, active surveillance is the preferred treatment for very low risk and low risk prostate cancers as it delays the radical treatment without compromising oncological outcomes. Most of the societies would advise for a confirmatory biopsy because many of the cancers are missed, and this leads to a reclassification in 20 to 30% of men. The active surveillance eligible patients which upgrade to grade group 2 on prostatectomy specimens, they have favorable outcomes, and there are many studies in favor of this. However, those which progress on a confirmatory biopsy, the outcomes of these patients is not known. The present study divided the patients into 2 groups, the immediate radical prostatectomy group, which were the patients with grade group 2 or 3 on an initial biopsy, and they underwent a radical prostatectomy within 6 months, and the active surveillance group, which were the grade group 1 cancers, which upgraded on a confirmatory biopsy, and then they underwent a radical prostatectomy. It was a retrospective study done in MSK from 2000 to 2016, and the outcomes that were taken were the biochemical recurrence, salvage treatment, and adverse pathology at radical prostatectomy. The adverse pathology was defined as any upgradation to grade group 3, 4, or 5, any seminal vesicle involvement or lymph node positivity with or without extraprostatic extension. There were 4,009 patients in the immediate RP group and 321 in the active surveillance group, and the median time from initial to confirmatory biopsy was 4.3 months. Both the groups were comparable in the terms of clinical characteristics. An important point to note was that prior to a confirmatory biopsy, 62% of patients underwent an MRI. That is, the confirmatory biopsies included both the MRI targeted and the systematic biopsies. Also, both the groups were comparable in terms of the pathological characteristics on the radical prostatectomy in terms of lymph node invasion, seminal vesicle invasion, or positive surgical margins. Both the groups were comparable. Coming to the results, the adverse pathological outcomes were significantly higher when extraprostatic extension was not included. That is 35% versus 27%, with a difference of 8.2%. The biochemical recurrence rates were lower in the active surveillance group, and as shown in this figure. Also, the salvage treatment-free survival was superior in the active surveillance group with a hazard ratio of 0.67. Taking into account where the biopsy was done, either internally or externally, there was no difference in the results. And a sensitivity analysis was performed with only grade group 2 patients, and this also showed similar results. In terms of all the 3 factors, that is biochemical recurrence, salvage treatment, and adverse pathology. Coming to the discussion, cancers with a pathological upgrading on confirmatory biopsy are significantly less aggressive than those of the same grade detected at diagnostic biopsy. Adverse pathology was more in the immediate RP group, and this closely was related to the original biopsy Gleason score. And the biochemical recurrence-free survival and the salvage treatment-free survival both were superior in the active surveillance group as compared to the immediate RP group. The explanations which were given for an initial low-risk status portending a favorable prognosis even after upgrading on a confirmatory biopsy was probably the quantity of Gleason pattern 4 was less in the AS group. And also the second explanation was that as we have seen that 62% of the patients, they underwent a MRI targeted biopsy prior to a confirmatory biopsy. And this resulted in a grade shift or a Will-Rogers phenomenon, wherein the MRI, being a more sensitive investigation, picks up even the smallest quantity of higher grade disease. So the authors proposed, and again in these lines also, the authors have very carefully chosen only grade group 2 and not grade group 3, that for grade group 2 cancers, these patients might we might allow them active surveillance when they're upgraded to grade group 2 on confirmatory biopsy, keeping in mind the other clinical, pathological, and very importantly, genetic parameters which have come up. There were certain limitations of this study, that this was a retrospective study, and also the amount of Gleason pattern 4 and the prostate cancer volume, these were not available. And also the probability of receiving an MRI targeted biopsy, there was a difference between both the groups. So in conclusion, men with grade group 1 cancers on an initial biopsy who are upgraded to 2 or 3 on a confirmatory biopsy, they have better oncological outcomes than men who present with grade group 2 or 3 cancers on initial biopsy. And treatment recommendations should consider the diagnostic pathway, with active surveillance being a potential management strategy with intermediate risk cancers on confirmatory biopsy. But again, the entire intermediate risk cancer, they have written as the intermediate risk cancers, but this mainly applies to a favorable intermediate risk category. So what do the guidelines say? For the low-risk cancers, the EAU suggests performing an MRI before a confirmatory biopsy, and also whenever a confirmatory biopsy is being taken, both targeted as well as a systematic biopsy needs to be performed, a very strong recommendation. And when the patients who are on active surveillance and they have upgraded on a confirmatory biopsy and reveals more than 3 positive cores or more than 50% core, they need to be reclassified and treated actively. As for the intermediate risk disease, the EAU recommends offering active surveillance to highly selected patients with a grade group 2 disease, that is 10%, less than 10% pattern 4, PSA less than 10, less than T2A disease, and a low biopsy extent, which is defined as less than 3 positive cores, as well as a less than 50% core involvement. All the guidelines, EAU, NICE, NCC, and AU, ASCO, all the guidelines, they have an emphasis on patient selection and active surveillance to be given for favorable intermediate risk categories, with those which have a low volume of Gleason pattern 4, low PSA density. And there is a lot of emphasis on an MP-MRI targeted biopsy, as well as the use of molecular markers like BRCA1 and BRCA2, which might decide the fate of these patients, whether to be kept on active surveillance or treated actively. On critically analyzing the paper, there were two major things which I found out. One was whether this upgradation was actually a missed cancer or an actual biological progression. The authors say that these were the missed cancers, and the difference arose because of the diagnostic pathway, whether an MRI targeted biopsy was used or not. And secondly, another fallacy was that there was no subgroup analysis in those patients who were upgraded to grade group 2 versus those who were upgraded to grade group 3. And rest of the paper was pretty fine.